Welcome to this deep dive into the foundational principles of forensic medicine.
Thank you. It's great to be here to unpack this with you all.
Yeah, so today we are undertaking a highly structured, a really clinical exploration of Chapter 8 of Simpson's Forensic Medicine. We're focusing entirely on the assessment, classification, and documentation of injury.
Which is such a massive topic. I mean, it's the absolute core of the discipline.
It really is. And our primary audience today includes medical students, preparing for final exams, junior doctors who are seeking to solidify their medico-legal principles, and senior clinicians who might be revisiting these rigorous frameworks.
It's the frameworks that govern forensic documentation.
Exactly. And our central mission for this session is simple but profound. In the forensic arena, the words you use to describe a wound carry as much weight as the physical injury itself.
They absolutely do.
The integrity of criminal proceedings, civil litigation, and safeguarding frameworks, all of it relies on an architecture of precise objective language.
But before we dive into the actual pathology, it is really imperative to establish the parameters of our discussion today.
Right. The disclaimer.
Yes, the crucial disclaimer. Look, this deep dive is formulated as a conceptual guide to help you build and refine your clinical framework. We are going to examine the physiological mechanisms, the classifications, and the legal implications of trauma. But this audio analysis is not a substitute for the primary literature.
Yeah.
It's explicitly designed to be utilized alongside your textbook.
Yeah, we strongly encourage you to have Chapter 8 of Simpson's open right there in front of you as we progress.
The goal is to support your reading, to contextualize these concepts with clinical reasoning and give you those structural anchors for your practice.
So building on that foundation, we really need to address the core discipline of forensic medical examination. And that relies on an absolute bifurcation between observation and interpretation.
That's the trap, isn't it? The clinical reflex.
It is. The reflex is almost always to synthesize findings immediately into a diagnosis or a mechanism of injury. A patient presents with a swollen, discolored eye, and your immediate thought as a doctor is assault.
But in forensic practice, that reflex has to be completely suspended.
Suspended entirely. The foundational step is pure objective description. You have to document the dimensions in millimeters, the precise anatomical coordinates, the color variations, and the morphological features.
And the interpretation, the hypothesis of how those features were actually generated,
Yeah.
that can only safely follow a meticulously established descriptive baseline.
Yeah, because if you conflate the narrative provided by the patient or by law enforcement with your physical findings, you compromise the entire evidential chain.
And that distinction is the bedrock of forensic integrity. When an expert witness takes the stand, their credibility rests entirely on their ability to demonstrate that their conclusions are derived from objective morphology.
Not preconceived narratives.
Exactly, not narratives.
Yeah.
Which brings us directly to the medico-legal framework and the really severe consequences of terminological imprecision.
Words matter.
Words matter immensely. In a standard clinical environment, the priority is therapeutic triage, right? A physician in a busy, high-volume ER might casually dictate that a patient sustained a laceration to the forearm from a kitchen knife.
She's intending to communicate that the skin is breached and it needs suturing.
Right. Therapeutically, the exact nomenclature might not alter the immediate closure technique. But forensically, that single word choice is catastrophic.
Catastrophic. Let's actually use that specific example because the misuse of the word laceration warrants a much deeper analysis. It's arguably the most common pitfall for clinical practitioners.
It happens every day. Let's look at the pathology. A laceration is strictly defined as a tissue tear induced by blunt force trauma.
Blunt force, not sharp.
Exactly. It involves the crushing, the stretching, and the ultimate bursting of the integumentary layers.
A knife conversely imparts sharp force trauma. It elegantly parts the tissues without crushing them, creating an incised wound.
So if a clinician documents a laceration when the mechanism was actually a blade, they've inadvertently introduced a profound contradiction into the medical record.
And consider the trajectory of that medical record. Months or perhaps years later, that document is entered into evidence in a Crown court.
And the defense barrister, whose whole mandate is to introduce reasonable doubt, is going to seize upon that contradiction.
They'll tear it apart. They will interrogate the clinician, highlighting that the medical chart explicitly records blunt force trauma, whereas the prosecution is alleging an assault with a bladed article.
And then the barrister challenges the clinician's fundamental competence. They'll ask the jury, how they can trust the physician's broader assessment if they can't even differentiate between a crush injury and a surgical-style slice.
So the medical evidence, rather than clarifying the mechanics of the assault, becomes the exact instrument used to dismantle the prosecution's case.
It's a stark reminder. We have to speak the language of the law when we operate at the intersection of medicine and justice.
Speaking of the language of the law that requires us to understand how the law defines anatomical disruption, the colloquial use of the word wound encompasses almost any localized injury.
Sure, a scraped knee, a bruised arm.
Yeah, but within the jurisdiction of England and Wales, the legal definition is remarkably narrow. It's heavily predicated on structural anatomy. A wound is legally recognized only if there is a complete division of the entire continuity of the skin.
That structural criteria is paramount. The skin is a composite organ. To satisfy the legal definition of a wound, the trauma must breach the entirety of the epidermis, the outer cuticle, and sever the full thickness of the underlying dermis.
So if an injury merely scrapes away the epidermis, leaving the dermal layer intact, that's an abrasion, right?
Correct. It is not a legal wound. Similarly, think about an immense, deeply painful contusion where blood has extravasated into the subcutaneous fat.
A huge bruise.
Right, a huge bruise. That does not constitute a wound because the overlying epidermal and dermal architecture remains unified.
That raises a really critical distinction regarding internal trauma, though. What if a patient sustains a comminuted fracture of the tibia from significant blunt force, but the skin remains entirely unblemished?
Like a severe internal crush.
Exactly. Does the severing of internal tissues, muscle, fascia, and blood vessels qualify as a wound?
In the strict legal context of English law regarding wounding, no. The continuity of the external skin must be broken.
That's fascinating.
There is a caveat, though, for internal epithelial linings. A rupture of the mucosal lining of the inner cheek, the urethra, or the gastrointestinal tract can be classified legally as a wound.
Right.
Furthermore, returning to your fracture scenario, if that comminuted tibial fracture involves a bone fragment piercing outward, completely breaching the dermis and epidermis from the inside.
Compound fracture.
Yes. That internal to external disruption does fulfill the criteria for a wound.
This precision in defining a wound leads us directly into the legislative framework that governs non-fatal offenses against the person. We're talking primarily about the Offenses Against the Person Act, 1861.
Even though it was enacted during the Victorian era, its statutes remain the scaffolding for prosecuting violence today.
And for medical practitioners understanding the gradations of this act specifically, sections 18, 20, and 47 is essential. Clinical documentation often forms the basis for the specific charge brought by the Crown Prosecution Service. Let's examine the heaviest here, section 18.
Section 18 addresses wounding or causing grievous bodily harm, frequently abbreviated as GBH. Grievous bodily harm is legally interpreted simply as really serious harm.
Really serious harm.
What elevates an offense to Section 18 is the psychological element of the perpetrator, the specific intent to cause that severe harm.
The intent is the key word.
Because this intent demonstrates a high degree of malice, Section 18 carries a maximum penalty of life imprisonment.
And from a clinical perspective, we need to recognize that Section 18 is not restricted to just mechanical trauma, like beatings or stabbings.
Not at all. If an individual purposefully administers a toxicological agent or deliberately acts to infect another person with a severe transmissible disease, the resulting physiological devastation constitutes GBH with intent.
So the element of intent separates Section 18 from Section 20. Let's look at 20. It also deals with wounding or inflicting grievous bodily harm, but it applies when the specific intent to cause really serious harm cannot be proven.
Right. The perpetrator may have acted recklessly, perhaps intending only to cause minor fright or lesser harm, but their actions nonetheless resulted in a devastating injury.
So the clinical presentation of the victim in a Section 18 versus a Section 20 case might actually be identical.
Completely identical. For example, a profoundly fractured skull with an underlying subdural hematoma. The divergence lies entirely in the legal assessment of the assailant's mind.
Did they deliberately swing a heavy weapon at the victim's head with the desire to cause catastrophic damage?
Or did they recklessly push the victim, who then tragically struck their head on a curb? Because Section 20 lacks that specific malicious intent for severe harm, the maximum custodial sentence drops significantly, typically to 5 years.
And the physician's role is not to determine intent. That is the province of the court.
Exactly. Your role is to document the injury pattern so meticulously that forensic reconstruction experts can accurately model the force and vector of the impact. The jury will then use that physical evidence to infer the intent.
Stepping down the scale of severity, we encounter Section 47, assault occasioning actual bodily harm, or ABH. The jurisprudence defines actual bodily harm as any hurt or injury calculated to interfere with the health or comfort of the victim.
Provided it is more than merely transient or trifling.
Right. So in a busy clinical setting, ABH encompasses a vast array of common presentations.
It includes injuries that generally necessitate medical intervention, but do not cross the threshold into really serious harm. A classic presentation might involve a patient who has sustained a periorbital hematoma, a black eye, accompanied by an undisplaced nasal fracture, and minor superficial abrasions.
Or another frequent example is the fracture or avulsion of a tooth following a targeted punch to the maxilla.
Yes, these injuries significantly disrupt the patient's physiological comfort and structural integrity, securely anchoring the charge within Section 47.
So when violence escalates beyond non-fatal boundaries, we transition from the 1861 Act into the realm of homicide. The distinction between murder and manslaughter in the jurisdiction of England and Wales is highly nuanced.
And medical evidence often plays a pivotal role in establishing the parameters of the defense here. Homicide is the overarching legal category for the killing of one human being by another.
Murder being the most severe classification, it requires the perpetrator to be of sound mind and to unlawfully kill with the specific intent to kill, or crucially, the intent to cause grievous bodily harm.
That's a point people often miss. If someone strikes another with the intent only to break their jaw, but the victim dies from subsequent complications, that satisfies the intent requirement for murder.
Manslaughter, conversely, is bifurcated into voluntary and involuntary categories. Let's isolate voluntary manslaughter first.
Okay.
This implies the actus reus, the guilty act, and the mens res, the intent to kill or cause GBH, were both present. But a legal mitigating factor reduces the culpability.
Precisely. In voluntary manslaughter, the perpetrator intended lethal or severe violence, but the law recognizes a partial defense. This typically involves a profound loss of control, perhaps due to a recognized trigger or a state of diminished responsibility.
Like stemming from a recognized medical or psychiatric condition that substantially impaired their mental functioning at the time of the offense.
Exactly. Involuntary manslaughter is fundamentally different. There was never any intent to cause death or really serious harm. It generally arises in two ways.
Gross negligence manslaughter being the first.
Right, where a duty of care existed, but the conduct fell so egregiously below the acceptable standard that it demonstrated a blatant disregard for a massive risk of death.
And the second?
Unlawful act manslaughter. That's where an individual commits a dangerous unlawful act, such as a minor assault, that inadvertently and unexpectedly results in a fatality.
Having established that legal scaffolding, we really must now turn our attention to the biological reality of trauma. We are shifting into the physiological mechanisms detailed in the text, the body's chaotic response to injury.
It is absolute chaos at the cellular level.
When kinetic energy is forcefully transferred into human tissue, the biological reaction is instantaneous. Let's examine the cellular environment in the microsecond following a severe mechanical disruption.
When tissue is crushed, sheared, or lacerated, the structural integrity of the cells is compromised. The lipid bilayers rupture and the intracellular contents are abruptly expelled into the extracellular matrix.
And this chaotic spillage includes specific molecules known as damage-associated molecular patterns, or DAMPs.
Alongside highly specialized signaling proteins, appropriately termed alarmins.
Alarmins.
The presence of these intracellular components in the extracellular space acts as an extreme biological siren. It triggers the innate immune system, instantly shifting the local microenvironment from homeostasis into a state of acute crisis.
This triggers the inflammatory cascade, primarily driven by the rapid recruitment of white blood cells. The neutrophils arrive first, followed closely by macrophages, but their function in this acute traumatic phase is not merely reparative, right?
Far from it. It is highly aggressive. It is essentially a scorched earth biological defense mechanism.
Evolution has dictated that a breach in the integumentary barrier presents an immediate lethal threat of systemic infection.
Consequently, when the neutrophils and macrophages flood the injury site, they generate a highly localized cytotoxic environment. They release reactive oxygen species and proteolytic enzymes designed to obliterate any invading pathogens.
But the tragic paradox of this acute inflammatory response is that these cytotoxic chemicals do not discriminate.
They don't. They inadvertently degrade and destroy the surrounding surviving healthy tissue. The vasodilation and increased capillary permeability designed to facilitate the influx of immune cells lead to profound local edema, erythema, and hyperthemia.
And while this localized response is necessary for survival against a minor wound when the trauma load is massive, this inflammatory cascade becomes systemic.
leading to catastrophic downstream effects.
Which brings us to the most dreaded physiological sequence in emergency medicine, the triad of death. This interlocking cycle of physiological failures is the primary adversary of the trauma surgeon.
It is the ultimate enemy in the trauma bay.
We need to dissect the biochemical mechanics of this triad: metabolic acidosis, hypothermia, and coagulopathy. How do these three discrete failures initiate a lethal feedback loop?
It begins with hemorrhage. Massive trauma results in a critical loss of circulating whole blood, which means a drastic reduction in erythrocytes and consequently oxygen delivery to the tissues.
So faced with profound hypoxia, the cells abandon aerobic respiration and pivot to anaerobic glycolysis just to maintain basic ATP production.
Right, and the byproduct of this anaerobic pathway is a massive accumulation of lactic acid. This systemic flooding of lactate precipitously drops the blood pH, resulting in metabolic acidosis.
Simultaneously, the patient is losing thermoregulation. Heat is escaping through exposed body cavities through the massive loss of warm blood, and iatrogenically through the rapid intravenous administration of unheated crystalloid fluids.
Fluids given by pre-hospital teams just attempting to maintain blood pressure. But this plunges the core temperature, inducing severe hypothermia.
And it is the combination of the acidotic pH and the hypothermic temperature that devastates the coagulation cascade.
Exactly. The clotting cascade relies on a highly synchronized series of enzymatic reactions involving various coagulation factors. Enzymes are exceptionally sensitive to their biochemical environment.
They need a very narrow window of normal to work.
They require optimal temperature and optimal pH to function. In a cold, highly acidic environment, the kinetic energy of these enzymatic reactions plummets, and the proteins themselves begin to denature.
So the patient develops profound coagulopathy. Their blood simply loses the ability to clot.
Because they cannot clot, they hemorrhage further.
Yeah.
The increased bleeding worsens the loss of oxygen carrying capacity, driving deeper anaerobic respiration, worsening the acidosis.
And the continued blood loss further drops the core temperature, worsening the hypothermia, which in turn further degrades the enzymes, worsening the coagulopathy.
It is a terrifying, accelerating death spiral.
And this precise pathophysiology is why the paradigm of trauma surgery shifted away from definitive anatomical repair toward damage control resuscitation.
Yes. A surgeon will not spend 4 hours perfectly reconstructing a shattered pelvis if the patient is in the triad of death.
The immediate goal is rapid physiological stabilization. Pack the bleeding clamp, the major vessels administer warm blood products to correct the coagulopathy and hypothermia, and allow the intensive care unit to correct the acidosis before attempting definitive surgical fixation.
That is the essence of modern trauma care. Survival is dictated by a complex interplay of variables. The primary variable is the trauma load, the anatomical severity of the destruction. Some injuries are fundamentally incompatible with life regardless of medical intervention.
The second variable is the kinetic energy transfer. The physics of trauma dictate that kinetic energy equals 1/2 mass times velocity squared.
Therefore, the velocity of the impacting object has an exponential effect on tissue destruction. A low-velocity injury, such as a stab wound from a scalpel, creates a highly localized track of damage. If it avoids major vascular structures, survival is probable.
Conversely, a high-velocity projectile like a rifle round imparts a massive shockwave of kinetic energy that radially expands, pulverizing tissue, fracturing bones, and rupturing organs far beyond the physical path of the bullet itself.
Other factors naturally include the rapidity and sophistication of pre-hospital intervention, the patient's baseline physiological reserve, their age, cardiovascular health, existing comorbidities, and the unique aggressiveness of their host inflammatory response.
This interplay of variables perfectly illustrates the concept of complexity theory, which the text highlights in box 8.1. It is a fascinating lens through which to view human physiology.
Complexity theory forces us to abandon the reductionist view that the human body operates like a simple linear machine where specific inputs invariably produce predictable outputs.
And instead, it posits that the body is a highly complex, nonlinear, chaotic system consisting of billions of interacting components.
In nonlinear systems, an effect is not strictly proportional to its cause. A microscopic alteration in one physiological parameter, say a slight drop in the concentration of a specific clotting factor, can cascade through the interconnected networks, causing exponential, completely unpredictable shifts in overall systemic stability.
This phenomenon is scientifically termed extreme sensitive dependence on initial conditions. It is the biological equivalent of the butterfly effect.
Very much so.
So in the context of massive trauma, we shouldn't view death simply as the final step in a predetermined sequence.
That is correct. In complexity theory, death is viewed as an emergent property of the chaotic system. It is the moment when the sheer volume of cascading nonlinear physiological failures overwhelms the system's homeostatic threshold, resulting in a sudden catastrophic collapse of the entire organism.
Wow. Let us transition from the microscopic chaos of systemic failure to the macroscopic evidence left on the skin. We are moving into the categorization of trauma, starting with blunt force injury.
Blunt force encompasses trauma delivered by non-cutting edges involving mechanisms of direct impact, torsion, traction, and shearing.
And the most frequent presentation of blunt force trauma is discoloration of the skin. A critical clinical skill is distinguishing between transient reddening erythema and actual bruising, a contusion. Let's break down the distinct pathophysiological mechanics of each.
Erythema is a vascular response. When blunt force strikes the skin, the local capillaries and venules undergo immediate vasodilation, increasing local blood flow to the injured area.
However, importantly, the structural integrity of these vessels remains intact. The blood is still contained within the endothelial walls.
Because the blood is intravascular, if you apply firm digital pressure to the erythematous area, you physically compress the vessels, pushing the blood out of that specific capillary bed. The skin will momentarily turn pale or white.
This is known as blanching.
Once pressure is removed, the capillary bed refills and the redness returns. Erythema typically resolves within hours as the vasodilation subsides.
A contusion or bruise represents a fundamentally different pathology.
Yes, a contusion signifies structural failure. The blunt impact has delivered enough compressive or shearing force to physically rupture the small venules and arterioles within the dermis or subcutaneous tissue.
Erythrocytes' red blood cells are forced out of the damaged vessels and extravasate into the surrounding interstitial spaces.
Because this blood is now trapped outside the vascular network, applying pressure will not displace it. A true bruise, therefore, does not blanch under pressure.
This simple bedside blanching test is your primary diagnostic tool to differentiate between a physiological vascular response and anatomical vascular damage.
It's step one in assessment.
Once that blood has extravasated into the tissues, it becomes subject to the laws of physics, specifically gravity, and the anatomical pathways of least resistance. This leads to the phenomenon of bruise migration, which is a really critical forensic concept.
A bruise will not necessarily manifest at the precise point of impact. That is a vital caveat for any medical examiner.
Extravasated blood is a fluid. It will track along the fascial planes, those sheets of connective tissue separating muscle layers and skin pulled downward by gravity.
A classic example is a severe blunt force impact to the scalp, perhaps from a fall. The scalp is highly vascular and the blood pools between the galea aponeurotica and the periosteum of the skull.
And over the course of days, gravity will pull that fluid tracking downward over the frontal bone, settling in the loose areolar tissue around the orbits.
So the patient will present with profound bilateral periorbital ecchymosis, 2 black eyes, despite never having sustained any direct trauma to the face itself.
Consequently, you can document the location of a deep bruise, but you cannot definitively infer the point of impact based solely on its presentation.
There is, however, a highly specific exception to this rule of migration: intradermal or pattern bruising. These bruises act as a permanent localized stamp of the impacting object.
Why do these specific bruises stay exactly where they are formed?
It comes down to the microscopic architecture of the skin. If a blunt impact is delivered with highly focused superficial force, it may rupture the tiny capillaries located in the dermal papillae just beneath the epidermis.
And the connective tissue matrix in this upper dermal layer is incredibly dense and tightly woven.
Exactly. When blood extravasates into this specific dense microenvironment, there is simply no physical space for it to track or migrate. It is instantly trapped.
Because it cannot diffuse it, it perfectly mirrors the shape of the object that caused the rupture.
This is where forensic pathology intersects with pattern recognition. A victim struck by a vehicle might bear the exact hexagonal imprint of the radiator grille in intradermal bruising.
Or a victim who has been stomped on may present with bruising that meticulously replicates the complex tread pattern, the wear marks, and even the logo of the assailant's shoe.
Another classic patterned injury is the tramline bruise. Let's explore the fluid dynamics that create a tramline bruise.
A tramline or tram track bruise is the signature injury of a cylindrical weapon. Think of a police baton, a broom handle, a heavy cable, or a pool cue.
When the rigid cylinder impacts the skin, the area directly beneath the deepest curve of the cylinder is subjected to extreme compressive force.
This downward pressure physically crushes the tissue, forcefully squeezing the blood out of the underlying vessels and driving it laterally to the sides of the impact zone.
While the vessels directly under the center are merely compressed and emptied, the vessels at the lateral edges of the cylinder are subjected to extreme stretching and shearing forces, causing them to rupture.
The resulting presentation is highly distinct. Two parallel linear bands of bruising separated by a central pale area of completely unbruised skin.
And the width of that central pale area corresponds roughly to the diameter of the weapon used.
Which brings us to a topic that has historically caused immense controversy in forensic medicine: the estimation of a bruise's age based on its color.
For decades, the prevailing dogma was that one could visually analyze the chronologic progression of colors, red to purple to green to yellow, and state with certainty that an injury occurred exactly 72 hours ago.
But the modern text is unequivocal in dismantling this practice.
Attempting to date bruises solely by visual color assessment is scientifically indefensible and forensically hazardous.
The color changes in a bruise are driven by the biochemical degradation of extravasated hemoglobin by tissue macrophages, right?
Yes. Hemoglobin is broken down into biliverdin, which appears green, then into bilirubin, which appears yellow, and finally into hemosiderin, which is golden brown.
However, the kinetics of this enzymatic pathway vary enormously.
The rate of degradation is influenced by the depth of the bruise, the volume of extravasated blood, the ambient temperature, and the individual's specific macrophage activity.
Furthermore, a single bruise will not degrade uniformly. A large contusion might be purple at the center where the blood volume is highest, while the periphery has already metabolized into yellow bilirubin.
Precisely. Add to that the subjective nature of human color perception, the vast differences in underlying skin pigmentation, and variations in ambient lighting during the examination.
The margin of error becomes completely unacceptable for a court of law.
The only scientifically rigorous statement one can make regarding bruise aging is that the presence of yellow indicating the formation of bilirubin rarely appears before 18 hours post-injury.
Therefore, a yellow bruise is highly unlikely to be fresh.
But the inverse is not true. A bruise lacking yellow is not necessarily recent. Some deep contusions will heal entirely without ever presenting a visible yellow phase on the skin surface.
Furthermore, the examiner must be aware of post-mortem lividity. When a body lies in a dependent position, gravity pulls the static blood downward.
The sheer hydrostatic weight can rupture the delicate capillaries in the dependent areas, creating actual bruises hours after death. Assigning a chronological age to an injury based on a fleeting glance is a trap that modern practitioners must rigorously avoid.
Moving beyond the vascular damage of bruises, we must examine the disruption of the skin surface itself. Abrasions, colloquially known as grazes or scrapes.
Abrasions involve the frictional removal or destruction of the superficial epidermal layers. Unlike migrating contusions, an abrasion marks the absolute precise point of contact between the weapon and the skin.
Abrasions are exceptionally valuable forensically because they offer undeniable proof of surface contact, and crucially, they can reveal the vector of the force.
When a rough object slides across the skin under pressure, it exerts immense frictional drag. This dragging force shears off the microscopic layers of the squamous epithelium.
As the object continues its path, it acts like a microscopic snowplow, rolling up those sheared layers of skin and depositing them at the very end of the wound track. We call these deposits terminal epidermal tags.
So if you were examining a victim who was struck by a glancing blow from a brick or a pedestrian who slid across the tarmac after a collision, you can use magnification to locate these terminal epidermal tags.
If the tags are piled at the inferior edge of a vertical abrasion on the thigh, it mathematically proves the abrasive force moved from superior to inferior, down the leg. It is a vital piece of biomechanical evidence.
The morphological variations of abrasions are also instructive. We categorize scratches as linear abrasions typically caused by fingernails or sharp points dragging across the skin.
Scuffs or brush abrasions cover a broader surface area, indicating contact with a wide, rough surface like concrete.
Gouge abrasions occur when an object penetrates slightly deeper into the dermis before dragging.
Finally, we must emphasize the forensic significance of crush or parchmented abrasions. These occur when extreme sustained pressure is applied to the skin, compressing the epidermal cells and destroying their structural fluid.
As the damaged skin dries out, it becomes hard, leathery, and dark brown, a process known as parchmenting.
The most critical manifestation of a parchmented abrasion is the ligature mark found on the neck in cases of suicidal hanging or homicidal strangulation.
To conclude our analysis of blunt force trauma, we must return to the laceration. As we established earlier, a laceration is the tearing of tissue due to blunt impact.
The skin is trapped between the impacting object, a hammer, a dashboard, the ground, and the underlying unyielding bones such as the skull, the zygomatic arch, or the anterior tibia.
The sheer compressive force exceeds the tissue's elasticity, causing it to burst open. The margins of a laceration are characteristically ragged and irregular, frequently bordered by crushed, debrided, and bruised tissue where the blunt object made initial contact.
But the definitive pathognomonic feature of a laceration lies deep within the wound bed.
The definitive diagnostic marker is the presence of tissue bridging fibers. Skin is not a homogeneous material. It is a complex composite of varied tissues with distinct biomechanical properties.
Adipose tissue and skeletal muscle have relatively low tensile strength and tear easily under tension.
Conversely, peripheral nerve bundles, medium-sized blood vessels, and thick bands of collagenous fascia are highly elastic and possess significant tensile strength.
When blunt force violently stretches the tissue until it splits, these tougher structures frequently resist tearing. Instead, they stretch across the newly formed gap.
If you look closely into the depths of a true laceration, you will observe these intact threads, nerves, vessels, fascia spanning from one margin of the wound to the other.
These bridging fibers are undeniable proof that the injury mechanism was a blunt force tearing the tissue, not a sharp edge cutting it.
That structural reality provides the perfect transition into body section 4, sharp force trauma and complex patterns.
If bridging fibers are the hallmark of blunt force, their absolute absence is the defining characteristic of sharp force trauma. We are dealing with injuries caused by implements with a fine cutting edge, knives, surgical scalpels, broken glass, or sharpened ceramics.
When a sharp edge is applied to tissue, the physics change entirely. A blade requires minimal force to part the structural components of the skin. It does not crush or tear, it cleanly divides.
The resulting wound margins will be sharp, well-defined, and typically devoid of the marginal bruising or abrasions seen in blunt impacts.
Most importantly, because the sharp edge indiscriminately severs everything in its path, regardless of tensile strength, the wound track will be entirely clean.
There will be absolutely no bridging fibers traversing the gap of an incised wound. Let us clarify the nomenclature used to subclassify sharp force trauma. A frequent point of contention in legal proceedings is the distinction between a slash and a stab.
How does forensic pathology differentiate these terms? The differentiation is fundamentally geometric based on the dimensions of the wound relative to the vector of force.
An incised wound, commonly referred to as a slash or a cut, is an injury created by a sweeping or drawing motion across the surface of the body.
Morphologically, an incised wound is defined as having a length on the skin surface that is greater than its depth of penetration into the underlying tissue.
A stab wound, conversely, is generated by a thrusting motion inward. It is defined as an injury where the depth of penetration into the body exceeds the length of the wound on the skin surface.
There is, however, a critical biomechanical caveat regarding stab wounds that clinicians must recognize. The depth of the wound track is not necessarily equal to the length of the blade used.
That is a crucial point. If an assailant forcefully thrusts a 6-inch blade into a victim's chest, but the point of the knife strikes the sternum or a rib after only 2 inches, the forward progress is halted.
The resulting wound may measure only 2 inches deep, yet it was inflicted by a 6-inch blade. Furthermore, due to the compressible nature of the human abdomen, a forceful thrust can push the abdominal wall inward.
So a 6-inch blade can therefore create an 8-inch deep wound track if the tissue is compressed during the strike and then relaxes outward after the blade is withdrawn.
The physics of tissue elasticity also affect the surface length of the wound. The skin is under constant natural tension along pathways known as Langer's lines.
If a stab wound runs parallel to Langer's lines, the wound might appear as a thin slit. If the blade cuts across Langer's lines perpendicular to the tension, the elastic recoil of the skin will pull the wound edges apart,
creating a gaping wide defect that appears much larger than the width of the blade.
The text highlights in box 8.3 that sharp force implements are not restricted to conventional knives. Forensic examiners must recognize the weapon signatures of atypical sharp or pointed objects.
The geometry of the implement dictates the morphology of the wound. A screwdriver, for instance, does not have a sharpened cutting edge, but it has a pointed tip. It requires blunt force behind the thrust to penetrate the skin.
A flathead screwdriver might leave a slit-like wound with slightly bruised edges, mimicking a blunt knife. However, a Phillips head screwdriver will punch out a highly distinct cruciform or cross-shaped defect in the skin.
Scissors are unique because they consist of two bypassing blades. If thrust into the body closed, they act like a thick knife. But if thrust slightly open, the two distinct points and blades can create a complex Z-shaped or V-shaped wound track.
Chisels possessing a flat beveled cutting edge will leave sharply defined rectangular punch-type wounds. We must also address a hybrid category of trauma, chop wounds.
These are inflicted by heavy-bladed instruments such as axes, meat cleavers, or machetes. They represent the terrifying intersection of blunt and sharp force physics.
Chop wounds are incredibly destructive because they deliver the dividing capability of a sharp edge powered by the massive kinetic energy of a heavy, blunt weapon.
The leading sharp edge cleanly severs the superficial tissues, acting as an incised wound. However, the sheer weight thickness and wedge shape of the blade following the edge acts as a blunt instrument.
As the wedge forces its way into the narrow cut, it forcefully crushes the wound margins, resulting in extensive marginal bruising and abrasion.
The immense kinetic energy is frequently sufficient to cause devastating underlying damage, including deep groove bone fractures, the splintering of skeletal structures, or even traumatic amputations of extremities.
You are simultaneously documenting the clean severing of sharp trauma and the explosive crushing of blunt trauma within a single injury site.
Moving from weapons to unarmed combat, specific patterns of assault leave predictable diagnostic traces on the human body. Recognizing these patterns allows the forensic physician to reconstruct the dynamics of the altercation.
Let us start with the mechanics of a punch delivered by a clenched fist to the face.
When analyzing a punch, the external manifestation, typically a contusion over the zygoma or the mandible, is often less informative than the internal findings.
The examiner must routinely and meticulously inspect the intraoral mucosa. When a fist forcefully compresses the soft tissue of the lips and cheeks against the rigid, unyielding structure of the underlying dentition, the tissue is subjected to immense shearing and crush forces.
This frequently results in lacerations on the inner aspect of the lips or the buccal mucosa. In cases of extreme pressure, the examiner may observe precise patterned imprint bruises of the crowns of the teeth stamped directly onto the mucosal lining.
Identifying these intraoral lesions is vital for corroborating an account of blunt force trauma to the lower face. The dynamics change dramatically when the assault involves kicking or stamping.
The kinetic energy transfer from a shod foot swinging on the fulcrum of the hip is exponentially greater than a punch. The forces involved in a stamping assault are massive.
When a victim is supine and an assailant stamps forcefully on their abdomen, the abdominal wall is rapidly and violently compressed against the rigid vertebral column.
This sudden extreme deceleration of the internal organs frequently causes catastrophic internal damage. The vascular connective tissue tethering the intestines to the abdominal wall can stretch and tear, leading to massive internal hemorrhage.
Hollow organs such as the bowel or bladder can burst under the sudden spike in hydraulic pressure.
Externally, as we discussed with patterned injuries, the examiner must meticulously search for intradermal bruising that mirrors the geometric tread pattern of the assailant's footwear.
In the midst of an assault, the victim's innate physiological reflex is to preserve vital structures, leading to the formation of defense injuries. These injuries provide a compelling narrative of a conscious dynamic struggle.
Defense injuries are typically located on the extremities, as the victim interposes their limbs between the weapon and their core or head. The morphology of the defense injury depends entirely on the weapon deployed.
In a sharp force assault with a knife, the victim's instinctive reaction is often to grasp the blade in an attempt to disarm the attacker or push the weapon away.
This results in deep, severe incised wounds across the palmar aspects of the hands or the flexor surfaces of the fingers, frequently severing flexor tendons.
Conversely, in a blunt force assault, for example, a sustained attack with a baseball bat, the victim will typically raise their arms, crossing them over their face and cranium.
The resulting trauma will be localized to the extensor surfaces of the forearms or the ulnar aspect of the arms, presenting as profound contusions, deep abrasions, or underlying fractures of the ulna or radius, commonly referred to as perifractures.
We must also address one of the most complex and forensically volatile injuries, the human bite mark. A bite mark is an intricate hybrid injury.
The incisors and canines act as blunt instruments, causing crush abrasions, while the sheer force of the jaw can cause lacerations. But the primary focus for the first responding clinician is not complex odontological analysis. It is immediate preservation.
That cannot be stressed enough. Bite mark analysis by forensic odontologists is notoriously challenging due to the viscoelastic nature of human skin, which distorts incredibly under pressure and tension.
While the structural analysis of the bite mark is complex, the biological evidence it contains is transient and invaluable. Saliva is deposited during the bite.
Therefore, the absolute first priority of the clinician prior to any manipulation or cleansing of the wound is to swab the area meticulously for the assailant's DNA.
Only after the biological evidence is secured should you document the injury and immediately request a specialist forensic photographer. Do not attempt to photograph a bite mark with a standard clinical camera or a smartphone for evidential comparison.
The distortion will render the image useless in court. Which brings us to a specialized area of assessment: differentiating self-inflicted injuries from assault and the rigorous framework surrounding the documentation of torture.
How do we clinically identify wounds that were likely self-inflicted? Self-inflicted injuries, particularly those involving sharp implements, often display highly characteristic patterns driven by psychology and anatomy.
The hallmark finding is the presence of hesitation or tentative marks. These are multiple superficial parallel incised wounds located immediately adjacent to the primary deeper lethal or near lethal wound.
They represent the individual psychologically testing the blade or building the resolve to inflict the definitive injury. Anatomically self-inflicted wounds must, by definition, be in accessible locations.
Typically the anterior neck, the volar aspects of the wrists, or the anterior chest. Furthermore, the presence of older healed linear scars in these identical anatomical regions strongly supports a history of deliberate self-harm.
In stark contrast to self-harm is the investigation of torture. In these scenarios, the clinician's documentation serves not just a local court, but international human rights frameworks. This is where the Istanbul Protocol becomes essential.
The Istanbul Protocol is the United Nations manual outlining the international standard for the effective investigation and documentation of torture and other cruel, inhuman, or degrading treatment.
The protocol imposes a strict objective and standardized methodology upon the forensic physician. A clinician evaluating an asylum seeker or a survivor of state violence cannot simply state these scars prove the patient was tortured.
Such a statement is deemed too subjective and interpretive. Instead, the protocol mandates that the physician meticulously document the physical findings and then scale those findings against the specific history of abuse provided by the patient using a defined semantic scale.
Let's review that exact scale because it forces clinical rigor into an often highly emotive situation. The scale requires the clinician to categorize the correlation between the physical lesion and the historical account.
First is not consistent. The lesion could not possibly have been caused by the trauma described.
Second is consistent with. The lesion could have been caused by the described trauma, but it could also have been caused by numerous other mechanisms.
Third is highly consistent. The lesion could have been caused by the trauma described, and there are very few other possible causes.
Fourth is typical of. The appearance is usually found with this type of trauma, but other causes are still remotely possible.
Finally, diagnostic of. The physical appearance of the lesion could not possibly have been caused in any way other than the specific method of torture described.
By utilizing this rigid semantic framework, the physician provides the tribunal with an objective graded assessment of the evidence without overstepping into legal adjudication.
This emphasis on strict frameworks leads us to our final major section. Body, Section 5, Evidential Architecture. This section deals with the practical physical act of documentation and photography.
You mentioned earlier that translating clinical terminology into lay language is essential for the courtroom. Let's detail the precise checklist for documenting a single injury in a forensic chart.
When documenting an injury for a medico-legal report, the clinician must assume the document will be scrutinized by individuals with no medical training.
While you must record the accurate medical terminology for the clinical record, such as periorbital ecchymosis with associated zygomatic arch fracture, you must simultaneously provide the translation. A severely bruised eye with a fractured cheekbone.
The descriptive checklist is non-negotiable. Location. You must measure the precise distance of the lesion from fixed immutable anatomical landmarks such as the midline of the body, the sternal notch, or the acromion process.
Symptomatology. Document the presence or absence of pain or tenderness upon palpation. Dimensions. Record the exact size in millimeters using a rigid forensic ruler.
Approximations such as the size of a coin or about 2 inches are entirely unacceptable and will be destroyed in cross-examination.
Morphology. Describe the shape, the exact color or variations in color, the nature of the wound margins, sharp versus ragged, and the orientation or angle of the wound relative to the body's longitudinal axis.
The text provides exceptional detail in boxes 8.5 and 8.6 regarding the rules of forensic photography. It is an area where well-meaning clinicians frequently compromise the evidence.
Let's read it clearly. Using a smartphone to capture an evidential image, particularly of a patterned injury like a bite mark or a shoe print, is forensically invalid. Why is the hardware so restricted?
The primary enemy of forensic photography is lens distortion. Smartphones utilize wide-angle lenses to capture a broad field of view.
The optical physics of a wide-angle lens inherently introduce barrel distortion. This means that straight lines near the edges of the frame are mathematically bowed outward, making them appear curved.
If a forensic odontologist receives a smartphone photograph of a bite mark, the barrel distortion will have artificially widened and warped the dimensions of the dental arch, making it impossible to accurately match it to a suspect's dentition.
Therefore, the protocol strictly mandates the use of a digital single-lens reflex camera, a DSLR or equivalent mirrorless system fitted with a prime macro lens. The focal length of the lens must be 60 millimeters or greater.
Lenses at or above 60 millimeters provide a flat field of view that accurately replicates human vision and eliminates barrel distortion, ensuring the geometric integrity of the injury is preserved.
Beyond the hardware, the physical technique, the positioning of the camera relative to the patient, is governed by strict mathematical principles.
The alignment is critical to prevent angular or perspective distortion. The digital sensor inside the camera must be held perfectly parallel to the specific plane of the skin where the injury is located.
Put another way, the lens must be exactly perpendicular at a 90-degree angle to the injury. If the photographer angles the camera even slightly up-down or to the side, perspective distortion occurs.
A perfectly circular bruise will suddenly appear oval in the two-dimensional photograph. If an expert attempts to measure that oval image, their calculations will be fundamentally flawed.
This brings us to the use of the scale, specifically the ABFO number 2 scale, which is the L-shaped rigid ruler seen in professional crime scene photos. It isn't just tossed into the frame, its placement is an exact science.
The scale provides the known mathematical reference point. It must be placed on the exact same physical plane as the skin bearing the injury.
If the scale is held slightly above the skin closer to the lens, it will appear artificially larger relative to the wound, throwing off all subsequent measurements.
Furthermore, the photographer must be extremely careful not to press the rigid scale down too firmly onto soft tissue. Compressing the tissue will warp the skin, physically stretching or compressing the very injury they are attempting to document accurately.
The sequence of the photographs also follows a rigid chain of evidence protocol to ensure the images are legally admissible and logically coherent.
An isolated extreme close-up of a laceration is forensically useless if you cannot prove whose body it is on or where it is located. The sequence must tell the story.
Step 1. The identification shot. A photograph of the patient's face or an identification tag if the patient is unidentifiable or deceased.
Step 2. The locator shot. An unscaled, wider-angle photograph showing the injury in the context of a broader anatomical region, demonstrating exactly where on the body the trauma occurred.
Step 3. The scaled close-up. The camera is moved and the macro lens is focused perfectly. The sensor is aligned perpendicularly and the ABFO scale is positioned on the correct plane.
Step 4. A final identification shot to close the sequence, proving that the preceding images belong to that specific patient, effectively sealing the digital chain of custody.
The text notes that while 2D photography remains the standard, the future of forensic documentation, particularly for patterned injuries, lies in 3D surface scanning or photogrammetry.
3D imaging solves the ultimate physical limitation of 2D photography. The human body is comprised of curved surfaces, not flat planes.
If an assailant bites a victim on the lateral curvature of the bicep, a 2D photograph taken perpendicular to the center of the bite will inevitably suffer from distortion at the edges where the arm curves away from the lens.
3D scanning captures the exact millimeter-precise topography of the skin surface, mapping the injury across the curve.
The digital model can then be manipulated, flattened mathematically, and compared against a 3D scan of a suspect's teeth with a degree of precision that 2D photography simply cannot achieve. It represents the pinnacle of objective forensic documentation.
Let us synthesize the extensive frameworks we have analyzed today. We have detailed the absolute necessity of distinguishing objective morphological description from subjective interpretation.
We have unpacked the stringent legal definitions of wounding under the 1861 Act and the nuances of homicide legislation.
We've explored the chaotic biochemistry of the inflammatory cascade and the lethal mechanics of the triad of death.
We've established the diagnostic anchors differentiating blunt force contusions and lacerations from sharp force incised wounds, focusing heavily on the presence or absence of bridging fibers.
And finally, we have defined the rigorous physical and optical protocols required for evidential photography.
As we conclude the conceptual analysis, I would urge you to consider a profound systemic tension within the field, often referred to as the evidence gap in trauma care.
When a critically injured patient arrives in the resuscitation bay, the absolute overriding priority is the preservation of life.
To achieve that, trauma surgeons and emergency physicians must work aggressively and rapidly. However, their life-saving interventions frequently obliterate critical forensic evidence.
The precise morphology of a stab wound on the chest wall is often cut through by a surgeon performing an emergency thoracotomy.
The gunshot residue or trace DNA surrounding a bullet hole is washed away by nurses aggressively prepping the skin with betadine.
The patient's clothing bearing crucial blood spatter patterns is rapidly cut off and discarded onto the floor. The clinical priority is saving the biological life, but the forensic priority is saving the legal narrative.
Precisely. How does the medical system balance the chaotic, bloody reality of extreme trauma resuscitation with the pristine, mathematically exacting demands of the Crown Court?
It requires ongoing, rigorous cross-training between emergency clinicians and forensic pathologists to ensure that whenever possible, evidence is preserved without ever delaying life-saving care. It is an incredibly complex ethical and operational challenge.
That tension underscores exactly why a foundational knowledge of forensic principles is vital for every practicing clinician, regardless of their specialty.
Now, to reinforce the technical frameworks we've discussed, let us move into a dynamic clinical case review. We will utilize single best answer prompts to test your retention of the core concepts. I will outline the clinical scenario. We will pause briefly to allow you to formulate the correct terminology, and then we will dissect the answer and direct you to the corresponding section of Simpson's Forensic Medicine for further consolidation.
Ready when you are.
Case Prompt 1. You are the admitting physician in the emergency department. A patient is brought in following an altercation in a public house. They sustained a heavy blow to the parietal region of the skull from a glass ashtray. Upon examination of the wound, you note that the margins are highly irregular and ragged. The tissue immediately surrounding the defect is abraded. Utilizing a bright light and forceps, you examine the deep bed of the wound and observe several intact nerve bundles and vascular structures spanning the gap from one side of the tissue defect to the other. What is the precise forensic classification of this injury? Take a moment to think.
The definitive classification is a laceration. The critical diagnostic feature in this scenario is the presence of those intact nerve bundles and vascular structures spanning the gap, the bridging fibers. These fibers definitively prove that the tissue was pulled apart by the compressive and shearing forces of blunt trauma, overcoming the tensile strength of the fat and muscle, while the more elastic nerves and vessels stretched but did not snap. For a thorough review of this mechanism, revisit the lacerations subsection within the blunt force injury chapter.
Case Prompt 2. You are providing a medico-legal report for the Crown Prosecution Service regarding an assault case. The victim was struck forcefully across the anterior thighs with a heavy solid wooden broom handle. Your physical examination reveals extensive, profound bruising, tracking deep into the quadriceps musculature. However, despite the massive application of blunt force, a careful inspection confirms that the epidermal and dermal layers of the skin remain completely intact with no breach in continuity. Under the jurisdiction of England and Wales, does the severe blunt force injury constitute a legal wound for the purposes of a charge under the Offenses Against the Person Act 1861? Think about the anatomical criteria.
It does not. Legally, the classification of a wound requires the complete division of the entire continuity of the skin structure, meaning both the epidermis and the full thickness of the dermis must be breached. Despite the severity of the internal crushing and the resulting deep muscular contusion, the structural integrity of the external skin remains unbroken. Therefore, it was a severe injury, potentially an ABH or GBH, depending on the context and intent, but it is not a legal wound. This distinction is covered in detail in the injury and the law section of the text.
Case Prompt 3. A pedestrian is struck by a motor vehicle and thrown across the asphalt surface of the road. You are documenting the extensive abrasions on the patient's lateral torso. The forensic reconstruction team needs to ascertain the exact vector of the patient's slide across the road surface to model the collision dynamics. What specific microscopic morphological feature within the abrasion should you look for to definitively determine the direction of the abrasive force? Think about the frictional drag.
You must utilize magnification to locate terminal epidermal tags. As the rough asphalt shears off the superficial layers of the squamous epithelium, the friction rolls that tissue forward, depositing it in microscopic piles at the very end of the wound track. These tags point directly along the vector of force, indicating the exact direction the body was moving relative to the ground. You can review the mechanics of friction injuries in the abrasion section.
Case prompt 4. A victim presents with a severe sharp force injury to the anterior forearm following an assault with a broken glass bottle. The wound features cleanly divided margins with absolutely no bridging fibers. You use a rigid forensic ruler to measure the dimensions. The wound measures exactly 12 centimeters in length across the surface of the skin. Upon exploring the wound, you determine it penetrates 3 centimeters deep into the subcutaneous tissue and fascia. Based strictly on these dimensions, how is this sharp force injury geometrically classified?
This is classified geometrically as an incised wound, commonly referred to as a slash. The defining forensic characteristic is that the length of the defect on the surface of the skin, 12 centimeters, is significantly greater than the depth of its penetration into the underlying tissue, 3 centimeters. This indicates a sweeping or drawing motion across the tissue rather than a thrusting motion. This geometric classification framework is detailed in the sharp force injury section.
Case prompt 5. You are called to photograph an intricate pattern intradermal bruise on a patient's abdomen that clearly mirrors the tread of a boot. You have secured a DSLR camera with a 60mm macro lens and placed the ABFO Note 2 scale on the exact same plane as the abdominal skin. To ensure the resulting photograph is mathematically accurate and free from perspective distortion, what is the absolute critical role regarding the positioning of the camera's digital sensor relative to the injury?
The camera's digital sensor, and therefore the lens itself, must be held perfectly parallel to the plane of the injured skin, meaning the angle of the shot must be exactly perpendicular or 90 degrees to the injury. Any deviation from this perpendicular axis will introduce angular distortion, warping the geometry of the tread pattern and rendering it useless for precise forensic matching against the suspect's footwear. The optical physics of this process are outlined in Box 8.5 2D Photography of Patterned Injuries.
Case prompt 6. You are examining a suspect in police custody who alleges they were struck repeatedly across the back by a rigid cylindrical weapon, specifically a heavy police-style baton. If their account is accurate, what a highly specific pathognomonic pattern of bruising would you expect to observe on their dorsal surface, dictated by the fluid dynamics of a cylindrical impact?
You would look for the presence of tram line or tram track bruises. This distinct morphology consists of 2 parallel linear bands of contusion, separated by a central zone of pale, completely unbruised skin. It occurs because the rigid cylinder compresses the tissue directly beneath its center, squeezing the blood outward, while the severe stretching at the lateral edges of the cylinder causes the vessels to rupture, creating the parallel bruised lines. The fluid dynamics of this injury are explained thoroughly in the bruises section.
That concludes our rigorous review of Chapter 8. We have built the conceptual frameworks.
Now, it is imperative that you return to the primary text. Read the chapter closely and integrate these physiological and legal concepts into your practice.
And remember that in forensic medicine, clarity of description is the exact mechanism that protects the truth. Thank you for joining us for this deep dive. Keep analyzing, keep questioning, and keep looking closely.